Hello and welcome to the Japan Zoominar at UC San Diego. I'm Ulrike Schaede. I'm the professor of Japanese business at UC San Diego and the director of jfit, the Japan Forum for Innovation and Technology. We are at GPS, the School of Global Policy and Strategy. GPS is at UC San Diego. We are an international relations and public policy school, and one of our focuses is on the Pacific Rim. We have various degree programs, including a master's in international affairs with a Japan specialization. If these programs are of interest to you, please visit jfit.ucsd.edu. And jfit is our Japan Center, and our website is jfit.ucsd.edu. On that website, you will find that we have a newsflash that you can sign up to on that tab called News and Media. And right next to that tab is the Japan Zoominars tab, where you can find recordings of past Zoominars, as well as the opportunity to sign up for future ones. Please visit there if any of this sounds even remotely interesting. So the Japan Zoominar at UC San Diego is a weekly event. It starts at 4:30 every Tuesday, California time, which is Wednesday, 8:30 in Tokyo. And today we will talk about the pandemic, which is why you're here. Welcome. And please note that today at 5:30, we will add an information session by the Japan Society for the Promotion of Science, San Francisco office. They are here with us and will join at 5:30 for a 15-minute briefing on their programs, their fellowship opportunities. And I will say that as a past recipient of JSPS funding, this is worthwhile and you should listen. And if you have Ph.D. students or colleagues that are interested in doing research on Japan, tell them about it and they can join at this very same Zoom address. And then, of course, we have future events that you can see here. And I won't read out what they are, but look forward to seeing you next week when we talk about Japan's power and influence in the emerging world order. All right, so today we're going to talk about the COVID pandemic, and I have two guests, Professors Yuichi, whose international name is Ung-il, and Professor Byung-Kwang, who goes by BK, and I will introduce them shortly. But before I do, let me set the stage a little bit. What are we even talking about here? So I went in and I pulled some data for you, and just to remind you where Japan stands in the COVID pandemic. So here's a country comparison. And of course, the United States has been hit really hard, especially at the end of 2020, compared to Italy, which was also hit very hard. And these are, by the way, absolute numbers. And then Germany, the UK. And in comparison to those places, Japan looks very small. There is a blip there in December, January, but it doesn't look that bad. If I switch over to death, Japan also looks comparatively better than these countries that are pulled here. This is a ranking of total cases and fatalities, and Japan ranks 22 in both. When we do total cases per 1,000 or 100,000 people, Japan is not even on the list. So again, in international comparison, this doesn't look so bad. If we go to Japanese data, what I pulled here is from the Nikkei, which has actually a very nice website on these things. The Nikkei compares total accumulated number of cases, so 30 million in the United States compared to 461,000 in Japan. And then these are the death. And both, again, what we'll see here is it's not zero in Japan. There's something is not good in Japan, even though other countries were hit harder. This is a chart that I look at regularly. I find it quite interesting. So this is last week on March, so January through March. What you see here is total accumulated cases. So these are these 460,000. And this is the percentage of this is the fatality rate, and it is very small. And that's an interesting topic that maybe we will talk about today. Why what explains the shape of this curve. And then my final number is, this is also from Nikkei, which reports this daily, is the point that I want to impress here is that out of the 460,000 cases, 230,000 were in the Tokyo metropolitan area. The Tokyo metropolitan area, as many of you know, is the most densely populated metropolis in the world. It has 38 million people, which is basically the entire population of the state of California in the size of the city of Los Angeles. So it is actually a miracle that this number is not higher. There are other hotspots in Japan. Hokkaido stands out for reasons that are interesting to me. I think Aichi, which has a lot of production facilities maybe. And then of course, Osaka is also very densely populated. Okay, so those are the numbers. So let me stop my, my share. And here are my guests. Welcome, Professors Tae and Yu. So let me introduce you in that order. So Professor Yuichi Tae is the Dean of the School of Health Innovation at the Kanagawa University of Human Services. And that makes him a dear colleague of mine because the University of California, San Diego and the Kanagawa University of Human Services have an agreement of understanding that we're doing things together, and the two medical schools are doing things together, and also our global health program. Professor Tae is also a professor at the Department of Bioengineering at the University of Tokyo. He earned his PhD at the University of Tokyo and then spent several years at the Harvard School of Medicine as instructor, assistant professor, and returned to Todai in 2007, in 2013.
2001.
Oh, I'm sorry,
yeah.
One.
Sorry.
I got my notes wrong. He was a deputy director of the Center of Innovation for Self-Managing Health Society and became the dean of the Kanagawa School of Health Innovation in 2019. By training, he's an endocrinologist. I always get that word wrong. And his specialty biomaterial science and regenerative medicine. And he also has a new interest in MEBio. We're going to talk about MEBio later, Professor Tace. Thank you for joining us. And we're super excited that Professor Tae, you brought your colleague,
yes.
Professor Byung-Kwang, who is, by my understanding, one of the, if not the best trained Japanese epidemiologists currently. And that is because he's trained, I say this because you were a professor before at our sister university, UC Davis. You were at Harvard, you have an MA from Harvard University, a PhD from Johns Hopkins that everybody in the US now knows is the creator of the data that we look at for the COVID pandemic. You spent some time at the Stanford Center for Health Policy. You were through for 3 years. Dr. Yu was at the CDC, which also now every American knows, and then an assistant professor at the University of Rochester, which is a leading institution in the US for studying individual behavior on seasonal influenza vaccinations and timing and the whole vaccination process. And then you were at UC Davis. You have now returned to Tokyo to join Professor Tae at the Kanagawa School of Health Innovation, and you're an expert in preventative behavior and telemedicine. So thank you, Dr. Yu, for joining us today. So with that, Professor Tae, welcome.
Thank you very much for a very kind introduction. So, also thank you for providing a very relevant data about COVID-19. And Ulrike showed us the data, I think relatively widely provided to the US people. I think looking at those data, Japan looks good in comparison with the US and other European countries. But later, Dr. Yu will show us more detailed data. Actually, we need to compare Japan with other Asian and Pacific, Oceanian countries, I think, because we see something very different. And in comparison with those countries, I think we see some differences, but also some commonalities, which will probably provide us some clue to the solution of the whole problem, I think. And so, as much as I want to talk a lot about COVID-19, but actually we have a much better expert at our school. I'm very pleased to introduce Dr. Yu. He will provide us with latest info and analysis and his insight into the COVID-19 pandemic at this moment. So I'd like to pass the baton to Dr. Yu now. Ulrike.
Great, fantastic. So you, Sensei, you want to start us with some PowerPoints? Can you share?
Yes, I'm going to show PowerPoint in the screen. It is working right now? Okay, great, thank you. Okay. So my brief presentation is going to add more information, particularly the comparison of Japan with East Asian countries, and New Zealand, and also the US. So this is slides showing the total cases per 1 million in 6 countries. The first row is the US and Japan. And the second column shows the population size. So Japan is nearly 1/3 of the US. South Korea, about half of Japan. And Taiwan is nearly 1/4 of Japan. I also included the Philippines, which is doing a relatively worse job, and also New Zealand, because I want to avoid the discussion of just racial ethnic difference. When you look at total cases in this column, the third column, if you compare US and Japan, the ratio is 25 times higher in the US. But if you compare Japan to other East Asian countries, the South Korea is only half, and the Taiwan is incredible, only nearly 1% of the Japan after you standardize total cases per 1 million. And New Zealand is also doing a pretty good job compared to Japan as well. The Philippines is worse than Japan. If you look at the, another indicator, this per 1 million, it's quite a similar picture compared to the first table that I just shown. So US, Japan is looking much better than the US, but if you compare to other East Asian countries and New Zealand, Japan is not doing very well. This table shows a case fatality rate. So this is defined as the COVID related to this divided by COVID test positive. The far right column shows case fatality rate, which is dividing column 1 by column 2. They look somewhat similar, but still, if you look at the details, Japan, US somewhat similar, but Japan is the worst among the 6 countries in this table, particularly compared with Taiwan and New Zealand. These 2 countries have only a half of Japan's case fatality rate. So there are 2 possible interpretations why a case fatality rate of Taiwan and New Zealand are way much better than Japan and other countries. One, their standard of healthcare is way much better than other countries, but I don't think that's likely because you know, South Korea, New Zealand, US, Japan are quite comparable in terms of a healthcare system. So in my experience as a health economist for nearly 20 years, I don't think a healthcare system alone can explain a large proportion of difference between these developed countries. Therefore, it's more likely that Japan, US, and South Korea are more likely to have the smaller number of PCR tests. That means they are more likely to have PCR tests only among the people with symptoms or more severe cases. As a result, the denominator or the people with PCR positive tend to be much more serious compared to Taiwan and New Zealand. And also, this table shows the underutilizations of PCR tests in the countries other than Taiwan and New Zealand. So in this table, the second column shows the number of the PCR tests per standardized populations. And so within the parentheses, the number is indicating global ranking. Say the US is now 23rd. Japan is 144. Actually, it's a kind of misfortune that Japan remains nearly 140 and 150 in the ranking. Nearly for 1 year, entire year, Japan has been providing too few PCR tests for the people in Japan. Taiwan and New Zealand and also are very low, but their reasons are quite different from Japan and the US because South Korea and New Zealand used to be very high in global ranking in terms of providing a number of PCR tests. So as a result, particularly Taiwan and New Zealand became very successful in terms of controlling the domestic cases of COVID. As a result, they didn't have to provide too many PCR tests nowadays. Therefore, now Taiwanese and New Zealand governments provide much fewer tests, like 179, but they used to be very high in the ranking, Taiwan and New Zealand. The more explicit number is percent positive in PCR tests. The US is very high, 7.7%. Japan is 5%. The interpretation is relatively simple. The lower, the better. The better means there are adequate or sufficient number of PCR tests. So ideally, less than 2% at any time is a good indicator. Therefore, compared to this criterion of 2%, Japan is nearly 5%, is way much higher than 2%, means Japan did not provide sufficient number of PCR tests, and the US is worse than Japan. And the Philippines is somewhat similar to the US. There's another indicator showing that Japan did not provide the sufficient number of PCR tests, which is the ratio of 2 tests. So the PCR test, as you know, shows if you are currently infected or not. On the other hand, antibody test tells you if you had infection history in the past 3 months or 6 months. Depending on the type of your antibody test. Therefore, if you divide the positive of antibody test, which is column 1, say 0.1% in June last year in Tokyo. Also at the same time in June in Tokyo, the cumulative PCR test positive was 0.038%. So if you divide column 1 with column 2, you can calculate the ratio. This 3 means 1 in 3 infected persons had the chance to get PCR test and PCR positive. But unfortunately, I found that this Ministry of Health, Labor and Welfare's estimate, Japanese government estimate, is not accurate or correct. So with my additional calculations, actually the ratio is estimated to range from 2 to 17. Or if you account for the PCR test sensitivity, means PCR tests usually detect 70% of the infected persons. And then the ratio is even worse. Therefore, my conclusion is at least 10 times more infected people were in Tokyo as of June last year, and at least 4 times more patients or infected people in December 2020. So these estimates actually are submitted to the hearing on COVID-19 at the National Diet last summer, where Professor Kodama at the University of Tokyo gave a testimony. And, I made a report in English and Japanese as well. This is another picture showing the vaccination statuses. This may be shocking to you. If you look at the slide so far, US is not doing well, but if you look at this table, it's very encouraging for US residents because now the US is ranked number 9 in the world in terms of the proportion of the people vaccinated. It's as high as 27%. On the other hand, Japan is doing pretty bad. It's nearly 100 rank in the world, but still less than 1% received the vaccination in Japan for a number of reasons. From this slide, I want to show some brief findings of a very good review paper by Waters. That's published 2 months ago in Lancet. This shows the public and non-profit funding for the research, development and production of leading vaccine candidates. The top one is the ANGIS with Osaka University. This is the most promising vaccine candidate from Japan, but still compared to other candidates, is not so promising. So other candidates or other vaccines include AstraZeneca and BioNTech and Pfizer. They include some good informations. I'm sorry. Yeah, this is characteristics of the vaccine, sorry. And then this is the funding of a major vaccine candidate. Say the US government subsidized $2.1 billion for Sanofi, and a large amount of public fundings were available for developing a large number of the vaccines. So this is just a small fraction of big table appeared in Lancet. And, so this is, I think, the major policy issue down the road. So as of now, say, US is very successful in terms of increasing the number of vaccinated populations. But as this table shows, only 2/3 of the US populations are willing to get vaccinated. Therefore, once the vaccination rate hits nearly 60%, US may have a problem to increase the vaccinated populations, which should be at least 75% or 80% to achieve herd immunity in the US. Yeah, I think These are all for my.
Thank you very much for this great overview. It's very interesting. And so we're going to now have a conversation. Audience, if you would like to get into the mix, by all means, please write up your question into the Q&A portion of the screen at the bottom, and I will try to build your questions into the conversation as much as I can. So my first question is actually about, so you mentioned, Dr. Yu, that Japan is not doing this, not doing that, and the testing and the Ministry of Health, Labor and Welfare. Is there what is the Japanese equivalent to the CDC? So everybody in the United States knows that the CDC is actually in charge of this, and it's a center, and it's in Atlanta, and it's. But what is the Japanese equivalent of that? And is it the ministry that's in charge here, or who's in charge?
There is a center of infectious disease that's a national center and a part of the Japanese government, Ministry of Health, Labor and Welfare. But unfortunately, compared to the US CDC, so I would say Japanese CDC is not so large in terms of the funding. And the more serious aspect is that Japanese version of the CDC has very weak section of public health, epidemiology, and statistics. And they have a very good history of basic science in terms of the infectious diseases, but compared to the section of basic science, the section of public health of Japan's version of CDC is much weaker compared to the US CDC. So,
so the main actors here in Japan are from the ministry then? Is that the decision makers?
Yes, I would say, yeah, so yeah. Basically, the Ministry of Health, Labor and Welfare is leading a role, but still compared to other countries, they don't seem very, aggressive, or they, more enthusiastic in terms of providing many options. They tend to emphasize the behavior change of the people, rather than providing more PCR tests or providing vaccines rapidly.
So we have actually a lot of questions from the audience on this particular point, and a lot of them are in Japan and struggle to get a test, and others are in the United States and don't understand it. So Barbara, Hiroki, and others want to know, why is this testing so difficult? And why don't they just increase it? It sounds like a simple thing to do. And why is it so difficult to get a test? Or why is there not more testing?
Well, I think it's still very mysterious to me as well, why Japanese government did not help provide more PCR tests. Regarding the development of the vaccines, unfortunately, Japan is not very good compared to the global, standard. Japanese pharmaceutical company used to be very highly competitive up to 1980s, and also they have a very good history of developing novel vaccines, but up to 1980s. But after 1990s, vaccine industry in Japan is not very competitive. But good news is that, the technology of PCR tests are still very good, one of the best in the world. There are many competitive PCR test manufacturing companies in Japan, and they actually were very successful in terms of exporting PCR tests around the world. And actually some European countries gave official praise for these PCR testing and exporting companies in Japan. And actually some countries, like most of the countries around the world, try to restrict the export of PCR tests to other countries, because other countries try to increase the number of PCR tests in their own countries, but the Japanese government, for some unknown reasons, they did not limit any export of PCR tests. But still, to me, it's very mysterious why Japanese government was not so willing to increase the PCR tests.
So I'll have to invite a political scientist to the Japan Zoominar to figure out the answer to those questions. We have a medical question though that from Robbie, who wants to know about the false negative rates and how does that actually work? So I mean, when we do these comparison of data across countries, how do we figure in how good these tests are? You know, how good are the data that we're actually looking at when we compare UK cases to the US cases to Japan cases?
So you mean the false negative in PCR tests?
Yeah, or in the, yeah.
Yeah. In my understanding, false negative of the PCR test is a very trivial issue. I know some scientists think of that false negative as a serious issue, but so in my view, because I conducted some original cost-benefit, cost-effectiveness analysis of PCR tests. So false negative rate has very small impact. So at the very beginning, it's often reported that false negative is say 1%. But even the false negative rate is 1%, their impact on cost benefit, cost effectiveness is very, very trivial. And so nowadays, many papers already published, particularly from the China, that has already introduced a large size of PCR tests. So now the false negative rate is 0.001% or even less. Therefore, China and even other countries, as long as they introduce automated PCR test, false negative is usually less than 0.01%. And as I said, even if it's 1%, it's worth doing.
Sure. That's for sure. But there's I guess the health implication on if that number is high. So we get some questions on the vaccinations, and there are several of our audience are interested in a question that I'm interested in as well, which is has Japan imported some of these vaccines, and why is this rollout so slow? And I think it's fair to say that it's slow compared to other countries. And I guess there's a supply and a demand side to this, right? So there's a demand side on Japanese companies, Japanese people not wanting to get vaccinated, but also a supply issue. So could you talk a little bit about the state of the vaccinations and what, which vaccines have been imported and what's the situation there? Maybe Professor Tay, you want to chime in on that one?
Yeah, of course, the details should be provided by Dr. Yu, but I think as Dr. Yu already pointed out, up to 1980s, government was very willing to nurture the industry, the vaccination and so on and so on. But because of the several very unfortunate incidents surrounding the vaccination, some cases of adverse effects, Japanese the industry and the support from the government dwindled dramatically. I think that's my understanding, and so the Japanese government is very circumspect of taking up new vaccination. That's my understanding. Is that correct, Dr. Yu?
Yes, and also in my history of research of vaccination, so before around the year 2000, around the world, the vaccination is not a good business, unfortunately. Of course, there is a very steady demand for vaccines like child vaccination, like measles and rubella, but the profit rate for vaccination is very low. Therefore, most of the companies around the world are not willing to develop or expand their productions. So as a result, say around the year 2000, there was a very famous incident of contamination in the influenza vaccine manufacturing in the US. So at that time, I was working in the US. And actually, the contamination was found in a factory in the UK. But because US CDC inspectors found contamination at the factory in the UK, as a result, what happened? The supply of the seasonal vaccines in the US dropped by 30% because there were only 3 companies who provided seasonal flu. Just one factory, one manufacturing company had the contamination, and then supply dropped by 1/3. And actually, seasonal influenza is not a bad case. The most of the child vaccination in the US was provided by only single or 2 companies. Therefore, there was very high risk. If contamination is found, it's more serious drop in supply could happen in other vaccines. Therefore, after year 2000, the US government found that vaccine industry should be subsidized.
The industry aspect of this is super interesting, right? Because somebody has to make money on these vaccinations. So on the supply side, there's a challenge. And then there's also the demand side that people, like in the United States, don't want to get vaccinated.
Yes, in terms of demand side, as I just showed, the vaccine acceptance, the demand side is nearly the same between US and Japan. Both countries, nearly 2/3, 66% of the population are willing to get vaccinated for COVID vaccines. Therefore, demand side is the same between US and Japan. Therefore, I think the current problem in Japan is supply side, particularly the government. Why a government was so slow in importing, but according to the original plan of the Japanese government, the way much higher proportion of the Japanese should have been vaccinated because their original plan was to vaccinate 80% of the population before the Summer Olympic. So that was the original plan. They kept explaining from the last year. And actually that was one of the excuses why PCR tests are so few. So they said once the vaccines are available, we don't need a PCR test. And Japanese government, for some reason, was very optimistic about vaccine development and vaccine deployment. But unfortunately, as of now, their optimistic picture did not come true yet.
So we're getting some questions on some health issues and then also the fatality rate. And I want to take us also a little bit into social behavior and why, compared to the United States, the Japanese system is different. So the questions that we get from the audience around health are about whether, is there something about Asia that this bug is not as lethal compared to the United States, or is there something about the United States that makes the situation worse? Is there, the second part of this was about the older patients, right? Is there something, does this have to do with the aging of the Japanese society? And then Stevie has an interesting question, which I also want to build in. As you know very well, we look at to figure out the impact of this pandemic, we look at the excess death or excess mortality rates, right? And I just read an article in the Nikkei that in Japan, the excess mortality rate this winter was actually negative. There were fewer mortalities this flu season than they are in a normal winter. Can you explain that to us? Because in the United States, of course, this is how we assess how horrible this impact is. But is that not the case in Japan then?
So may I comment
Sure,
first?
Please.
And then, in terms of the social behavior, I think the Japanese culture is a bit different. I think you see the difference. I think like we don't shake hands. we just bow each other with some social distance. We don't hug much, less than the I think the US and European people. Those are, I think, one of the behavior, the difference in behaviors. But on the other hand, we ride on crammed trains and densely populated. So we really don't know. But in terms of the daily life, those things may be different. And the mask deployment, I think that has been already popular in Japan in flu season and so on. So people have not so reluctant to deploy masks in daily life because they are used to. And also there are many people wearing eyeglasses as well. I saw some paper eyeglasses also protective for infections. And in terms of the excess mortality rates, I also saw the data, and I think this year, this winter, we have very, very few flu-related deaths, pneumonia, influenza-related death cases because of the preventive measures originally deployed against COVID-19. Actually, that behavior change actually led to the general reduction in the infectious disease contraction. That's my understanding. But more rigorously, Dr. Yu, could you comment on that?
Yes, I totally agree with the comments from Dr. K. But changes in the people behavior definitely had a positive impacts on infectious disease mortality. However, in terms of other mortality rates of like cardiovascular diseases or pulmonary diseases or like diabetes, Japanese government did not release the detailed data yet. They released monthly about excess deaths of Japan, but I actually wrote a memo about their public data release. Their public data is not detailed enough in terms of what they are measuring because they didn't show which disease categories increase or decrease. Therefore, I would say we need more information, but at least we could say that Japan did not see the experience a huge upsurge in mortality during this pandemic season.
And so how about this, how about this question about whether the underlying health of the Japanese population, higher life expectancy, Japanese people seem to be aging much better than a lot of other people in other countries. Is that a factor at all, or is this actually not important? Because my understanding is a lot of the cases are actually young people, right? A lot of the mortality is among the old people, but the cases aren't necessarily. Is that right?
Yes, you are right. Yeah, and particularly in the current third upsurge, a large proportion of infected are actually the younger populations, but mortality is way much higher among older populations. My short answer is we don't know yet.
Right.
Fortunately.
We don't know.
So I want to talk a little bit about your research. So Professor Tay, you're at the school, you have this program about Mibyo.
Mm-hmm.
And I think this is something that is very interesting to us here because we have not heard about it. We don't know what it is. It's a Japanese word, but you spell it sort of that Americans can understand it. It's M-E-B-Y-O, right? But it's actually Mibyo, not yet sick. So can you talk a little bit about that initiative?
Thank you very much. So Mibyo actually is not American, not Japanese either. It's from Chinese, from old Chinese medicine. And Mibyo is a concept in which we capture the status of body and mind as changing continuously from healthy to sick, as opposed to the dichotomous thinking between the two. So we see it as a continuous gradation. So, and we think this concept is very important to incentivize people for taking behavior change by themselves. And I think your question about why Japanese people live longer and relatively resistant to the COVID-19 as other Asian Oceanian people. I think one reason may be, I think, probably lifestyle-related diseases, I think. So obesity, diabetes mellitus, hypertension, those kind of diseases, I think. And what strikes me most about the COVID-19 is the finding that so infectious diseases usually affect people in destitution, those who are in need, very thin, the low nutrition, so on, so on. But actually, COVID-19 infections affect more people in affluence, obese, with lifestyle-related disease caused by obesity and bad habits and so on, so on. So it's a kind of, I shouldn't say interesting, but very intriguing that this infection, this virus actually affects people in affluence, and we see some data that the people with obesity and other lifestyle diseases have more severity and also higher mortality in COVID-19. So in that sense, this tells us the importance of behavior change in daily life. And in the Mibio activity, we are developing tools to help people change their behavior towards better health.
So that's, of course, one of the key take. If you look at this as a longer thing, and hopefully this whole COVID thing will soon be a thing of the past, and we can analyze this a little bit more. But hopefully, one of the big things that will come out of this experience is what we can do to prepare to be better, right? And change our behaviors, eat better, move more, do all kinds of things. But so as doctors that study and as health economists, how do you think about, how do you affect behavioral change in people? And what does it take? So one of the, let me just maybe double down on that question. So one of the things we saw in the United States is that in the early stages of the pandemic, when people didn't know somebody who was sick, or didn't know from anybody who knew somebody who had passed away, they were thinking, oh, this doesn't affect me, and they weren't willing to change their behaviors. But as more and more people were affected by this, Americans too kind of put the mask on and follow the requests by the government to behave. So why? How can we do this, right? How can we change people's behavior without such a horrible threat? Is there a way to affect behavior without first having to go through a pandemic?
So let me comment first, and then Dr. Yu, because he has some new method to change people's behavior. So in terms of the Mibio, we have been developing a Mibio index with which we can show people where they are standing in the gradation between healthy and sick. And in terms of a Mibio index, we think there are 5 requirements for the index. First is predictive of future health risk. Second, personalized. Third, continuous and dynamic. Fourth, easy to use and cost effective. And the fifth, scientifically evidenced. And among those 5 items, we find the first, prediction ability, most important, because it will better incentivize people. If you are told, oh, you are obese, or you eat too much, you have very bad behavior, you don't get, I think, persuaded, I think. But if someone shows you, if you continue your lifestyle like this, in 3 years, you will get like this, you will get sick or something like that, it will, I think, better incentivize people. So yeah, so the key, like you said, is to help people put themselves in someone else's shoe. So someone who already developed diabetes, or someone suffered from heart attack. But it's very difficult, I think. You need imagination. But we doctors have to help them to envision their future images. And Dr. Yu, I think you have a better idea to help people do that.
No. Yeah, I chanced to spend many years on how to change behaviors. So I would say roughly there are two types of behaviors, like short-term and long-term. A short-term behavior change, like one-time vaccinations. And the other is long-term, like wearing mask every day. There are two concepts that really matters. One is time cost. So the other is risk perceptions. Why time cost is important? Say, even in the case of seasonal influenza vaccinations, even there is no out-of-pocket payment, means you don't have to pay, but still not everyone comes to clinic for vaccination. Why? Because time cost matters. Because you don't want to give up your time that can be used for your leisure or other reasons. Therefore, time cost is important also in terms of long-term behavior change. Like wearing a mask every day is actually a huge long-term commitment. Therefore, you need other, idea to change their behavior. And actually, money does not work. Even if you pay for someone to come to the clinic for vaccination, again, money did not work, unfortunately, so far. And even money did not work, say, please stop smoking. If you stop smoking, I can give you like $500. And there are millions of studies already conducted. Unfortunately, nothing worked in the long term. But again, the long-term behavior change is very difficult. So as I said, risk perception is a good concept. Say, in the last H1N1 flu pandemic, nearly 10 years ago, I wrote a simulation paper, and I found that when the people hear the news of increasing pandemic, they change behavior. They are less likely to go out. Therefore, in order to change or affect risk perceptions, transparency or the release of very good data on epidemic, that really is giving people to change. Of course, as Ulrike said, if you have your family seriously affected by the disease, but if you have many reasonable numbers in the news, that also really matters. I think, therefore, as long as we provide the accurate information, we can change behavior. But if in the case the pandemic continues, like 2 or 3, 4 more years, it's a nightmare scenario. But we need another type of intervention to change instead of just giving information. So my very kind of bizarre idea is using theater skills that I just recently started to use to change behavior for diet. So we use theater techniques, and we do some rehearsal how to change behavior. So because it's a long story, I would stop here. But there are some ideas we public health people have.
So we do this a little bit in management now. Use drama, music, as basically as interventions for team building. And what you're saying is, if you role play, then there could be a way of increasing empathy or self-awareness of. So, you know, we're almost out of time, but we have one question from Taka that I want to ask, which is actually very interesting in international comparison, and it has something to do with incentive setting and behavior. And that is, there's a real difference between the United States and Japan, and it's a public policy question. I'm sure you have some thoughts on it, in how the government is telling the people what's going to happen. In the United States, the government is saying, it differs by state, but let's just say California, the government says if the rate of infected people or positive tests, or, you know, so there's some ratio and some rates, and if this drops below a certain percentage, we will open back up and you can go back out and go to the restaurant and meet your friends. Whereas in Japan, there's a date. Germany, I think, does the same thing. They set a date and they say 2 more weeks, but in a way that's a little bit funny because we don't know what's going to happen in 2 more weeks. So is the government in Japan setting itself up for some trouble by setting these end dates of a lockdown, which without knowing what the health situation is actually going to be in 3 weeks from now?
Yeah, Dr. Yu, I think this better be handled by you, I think.
Okay. Yeah, of course, if you use mathematical simulation model, you can predict like 2 weeks from now, if say you start a partial lockdown, epidemic is going to be much lower. So within 2 weeks, we could predict this type of situations. But unfortunately, in the case of Japan, they were not willing to show what the prediction by mathematical simulation. I think that's a problem. I believe definitely they have their own research group within the Japanese government. They are simulating using a computer how the situation is going to be in 2 weeks. But that type of prediction should be released, in my view. But so far, Japanese government did not do so. And I think most of the government did not do so for many other reasons, but to me, to convince the general public, the more data release is needed for the prediction. Otherwise, people, become less interested in the government recommendations. Just give the end date is not, I think, not convincing enough.
What is the current situation in Japan in terms of credibility of the government? Are people generally believing that the government has a good handle on the situation, or is there a lot of skepticism or resistance, or what's the social situation right now?
So it's a kind of very difficult question, I think. But according to the poll, there is certain skepticism, I think. I have to admit, yes. So
people are not trusting the government is doing the right thing.
Not 100%, I guess.
Yeah.
I'd say. Yeah. But it's always there's something political, so I should be very
well, but this has something to do with the research you're doing, right? So because credibility would be very important. So what would be from a public health perspective? If we want to be innovative around this, right? So I wouldn't want to be in the government right now. This is a horrible situation for any government to be in. You cannot win. If you go one way, people are angry. If you go the other way, people are angry. So what would be from the medical perspective, right? So if you just think of this as doctors, not as politicians, what would be the optimal way of handling this situation?
So like Dr. Yu already pointed out, I think transparency is very important. So divulge all the info and data. If they do the simulations, not just one method, but they should try several different methods and show different results. And what's the worst, what's the best in the entirety of the whole intelligence, I think. So I think measures from the intelligence point of view, I think we need more activities in Japan. What do you think, Dr. Yu, about that?
Yeah, I totally agree with you.
All right. Well, so thank you, gentlemen. Time is up. It was great to have you both, and I hope we can get you back at some point when the thing is over. Everybody wants this pandemic to be over, and let's hope that that will indeed be the case. Until then, please keep up your good work and keep us safe and help Japan weather this pandemic. So thank you very much. And audience, please stay on if you are interested in joining us for an information session on the funding opportunities provided by the Japan Society for the Promotion of Science. And they're joining us now. So
thank you very
Professor
much.
Tay, Professor Yu,
Thank you.
thank you for joining us.
See you. See you. See you around.